These are our disclaimers. It's an honor to be able to represent and lead off our team. And that is a really critical aspect of our team at Wake that manages brain metastases, because this is truly a team sport and a team activity, managing patients with brain metastases. So we're going to start out by giving an update of brain metastases and management in 2023, and move on to the challenge of managing apparent radiographic progression. Then my colleague, Dr. Strowd, will talk a bit about the different treatments for post-SRS progression and necrosis. I will talk a bit about LITT for biopsy-proven necrosis and what the recent advances have been and data. Dr. Laxton will speak regarding benefits of early intervention and go over some cases. And then I will come back and circle back and talk about the future, how we employ SRS in the future in cases where patients have been treated with laser. So a bit of an update and kind of reminder, in 2023, brain metastases are quite common. About 200,000 patients are diagnosed with brain metastases every year in the US. About 50% of those patients have lung cancer, and then other types of cancers that spread to the brain include commonly melanoma, renal cell, and breast cancer. Now, the increase in incidence is related to improved staging MRI, better quality MRI, and also better treatments of extracranial disease that ultimately leaves the brain as a sanctuary location where brain metastases can ultimately form. Now, just to give you an idea, if brain metastasis were its own primary cancer, it would be the third most common type of cancer in the US. That's just how common. So this is a very common issue, and thus is very relevant to all oncologists who practice and treat patients with metastatic disease. 40% of patients with metastatic disease ultimately develop brain metastases, and then 200,000 patients in the US each year. Next slide, please. So we have data from Wake Forest that actually demonstrates very clearly that patients with brain metastases, if the brain metastases are treated early and prior to their becoming symptomatic, the patients do better. Survival is better, and the likelihood of dying of brain metastases is less, right? So what is the corollary to this finding is that, one, it is beneficial to do good staging on patients where their metastatic disease can potentially go to the brain, such as any patient with stage 3 and beyond lung cancer. But then any metastatic patient with melanoma, renal cell, breast cancer, the brain should be staging the brain should be part of the staging, and this can improve patient outcomes. Next slide, please. And I guess another corollary to that is that after treatment, patients should be followed with surveillance scanning, because again, if we can catch disease prior to it becoming symptomatic, we can do those patients some good and improve their survival and likelihood of dying of brain metastasis. Now, what are the options presently for treatment of patients with brain metastases? So, surgery for patients with larger symptomatic metastases is very reasonable, and has been shown to be often better than a radiotherapeutic alone option. So as part of surgical management, laser is just another way of doing surgery, but laser is a bit more, it can be used in some cases where the lesions may not be accessible to surgery. Patients with few metastases can get SRS alone. Patients with numerous metastases or leptomeningeal spread can have whole brain radiation, or now the newer version of hippocampal avoidant whole brain radiation. And systemic therapies are being integrated into the upfront treatment of patients with brain metastases, particularly small cell lung cancer. The blood-brain barrier seems to break down for this particular type of cancer, and it is chemosensitive enough where oftentimes patients with small lesions with small cell lung cancer can have those lesions treated with chemotherapy alone, they'll respond. Patients with melanoma and who are going to receive dual immunotherapy, there are now a couple of papers that show that this is a reasonable approach. You have to be very careful. The inclusion criteria in those studies was patients with asymptomatic metastases and ones that were not, the other ones that are essentially small. So this is an option for patients with 1 centimeter or less metastases who are going to be receiving dual immunotherapy for melanoma. Patients with EGFR ALK mutated lung cancers, there are now 3rd generation targeted agents that do cross the blood-brain barrier, and these are reasonable upfront options for patients who have brain metastases that are, again, are asymptomatic and less than 1 centimeter. And then finally, HER2 positive breast cancers, there are now multiple targeted agents that do cross the blood-brain barrier with a measurable response. I think with the breast cancer patients, we tend to now, at this point, still prefer upfront radiotherapy option in cases where radiosurgery is an option, just because the response rate is likely a bit higher. But this is definitely a this is a treatment option that is presently evolving and is likely to change over time. Next slide. So the practitioners are becoming more and more aggressive with radiosurgery. We are treating larger lesions than we had ever done before. We're treating more lesions than we ever have before. It's not rare now for a patient with 10 metastases and sometimes slightly greater to receive upfront radiosurgery. Also, it's not unusual anymore for patients with, 3 centimeter brain metastasis that is not resectable to have radiosurgery, hypofractionated radiation, or even stage radiosurgery as ways of, if the lesions are not accessible. What this increased aggressiveness of treating brain metastases with radiosurgery has led to is an increased number of patients across the country that are getting radiosurgery, and also an increased toxicity, things like radiation necrosis that happen just because you treat more patients. And if 7% of your patients have radiation necrosis, then 7% of 100,000 is definitely more than 7% of 50,000, right? And so, and then also being more aggressive with larger lesions and being more aggressive per patient leads to greater chances of things like radiation necrosis or tumor progression. And so that ultimately sets the stage for a major issue that we as practitioners of treating patient with brain metastases have to actually deal with on an everyday basis. Next slide. So we are getting more distant brain failures, more local failures, more radiation necrosis. Next slide. So as a result of patients who have, or as a result of treating patients with radiosurgery, we need to follow them up. We need to assess for new metastases. We need to assess for the success of our radiosurgery, and we need to assess for toxicity, right? So how do we do it at Wake? First, a scan we generally get at a little bit shorter interval just to rule out an aggressive treatment failure, either aggressively behaving, a tumor is locally failing, or rapid numerous distant brain failures. So we get the first scan a little bit earlier. Then after that, every 3 months for approximately 2 years. What we do after that is every 4 months for a year, and then every 6 months, years 4 and 5. And there is some data that shows that if patients have disease that is well controlled and they haven't had any events by year 4 and 5, that the number of scans you have to do after that is probably not that many, right? But again, this is data that is continuing to evolve, but it does appear that events tend to plateau after year 5 if they don't have any events prior to that. So what do we do when patients have new brain metastases? At Wake, we actually came up with what they call brain metastasis velocity. It is a biomarker showing how aggressively the brain will be reseeded with cancer. Next slide. And so getting new brain metastases is a very common thing. If somebody has a single brain met from cancer and you follow them out, by a year out, the likelihood of them developing at least another one is essentially about 30%. If anything more than that, and you're pushing 50% likelihood of having a new brain metastasis by a year out. So patients really need to be followed over time to catch these distant brain failures. Next slide. And so I had mentioned brain metastasis velocity. We use this as a biomarker to help us sort of triage patients for what's the next right treatment to give. At Wake, we came up with the brain met velocity. We used 9 major academic centers in the US and Canada to validate our data, and then the Japanese also helped to validate our data. If you can see, these Kaplan-Meier curves look essentially the same. So the brain met velocity works whether you're in the US, whether you're in Japan, and whether you're at Wake or elsewhere. And so if patients have a low brain metastasis velocity, their survival is good and they're less likely to die of brain mets. If they have a high brain met velocity, their survival is much worse, and the likelihood of their dying of brain metastasis is actually quite higher. And maybe the patients with a high brain met velocity might be better candidates for whole brain radiation or a trial. Next slide. So the trial that we have, and I'm one of the co-PIs on across internationally, is the NRG-BN009. We're randomizing patients to SRS or whole brain radiation after, if they have high brain met velocity. Patients with low brain met velocity, we just keep on going with further SRS, and intermediate, we consider further SRS or the study. Next slide. So, as I had mentioned, there are, because of our increased aggressiveness, there are increased numbers of patients with these post-treatment imaging events, right? So the likelihood of a local failure is related to the size of the lesion, right? So anything 3 centimeters above that you treat with radiosurgery, the chances of a local failure is like nearly 2/3 by a year, right? But small lesions are very well controlled and are 90% likely to stay that way at least for a year. Next slide. And so what can happen is these different imaging phenomena. You have a pseudoprogression, which is related to endothelial injury and is a transient increase in the size and enhancement of the disease that was treated. You have radiation necrosis, which is a distinct disease process really related to a cascade, like a cascade mediated by the VEGF molecules. It's a molecular cascade that is similar in the brain as what like ARDS is in the lung. It's like an inflammatory cascade, can kind of get out of control, become very symptomatic, patient even die from it. But ultimately, the main morbidity is that these patients can have significant and sometimes severe neurologic deficits. Next slide. So as I had mentioned, the radiation necrosis is mediated by VEGF, and this gets to the mechanism by which things like surgery, bevacizumab, and LITT can be helpful for treating radiation necrosis, right? So if the radiation necrosis is within this molecular soup around the brain metastasis and you resect it, or if you ablate it with a sufficient amount of heat, then all of a sudden that is either no longer in the patient or has been denatured to the point where the cascade cannot continue. Since it's mediated by VEGF, if you treat the patient with bevacizumab, that can actually halt the cascade and patient actually can feel better and have imaging response. Next slide. So pseudoprogression generally occurs within 6 months of the treatment being done, whereas radiation necrosis tends to occur greater than 6 months out. These are sort of blurry borders, so the pseudoprogression can cross the border of past 6 months, and radiation necrosis can occur inside of 6 months, particularly with larger lesions or higher dose. Next slide. Right. So The likelihood of radiation necrosis is also related to volume, but essentially in all comers, the longer you wait, the higher the likelihood at some point someone can get radiation necrosis until that plateau happens approximately 4 years out. So most of the radiation necrosis events tend to occur within the first 2 years, but it really doesn't plateau until approximately 4 years. Next slide. And as I had mentioned, the size of the index lesion is very correlated to the likelihood of necrosis. So larger lesions, anything greater than 1.5 cm, the likelihood is the cumulative incidence of radiation necrosis over a lifetime ends up being greater than 50%, whereas smaller lesions tend still to be rare. Other factors that can affect the likelihood or increase the likelihood of radiation necrosis: prior radiation, so if they've had prior whole brain, if they've had prior SRS to that lesion, you're gamma knifing it again, you're treating it a second time. If you have stage radiosurgery, you're treating a lesion a second time, or giving a boost to a lesion after it shrunk some. And then immunotherapy. And so as we know, immunotherapy is very common these days. About half of our patients who are eligible for radiosurgery are either on immunotherapy or eligible to receive it, right? So that's a large number of patients. And so again, because immunotherapy is becoming very common, it is something where the advent of common immunotherapy is another one of the things that's increased the likelihood that we get these imaging events after SRS that have to be managed by neurosurgery, where LITT is one of the tools that can be helpful. And another sort of corollary to that is that patients who receive immunotherapy, using steroids on these patients, any dose greater than 2 milligrams a day of Decadron can affect the effectiveness of the immunotherapy. So it's something really important for us to consider. Next slide. So this is just a slide from one of our Wake Forest papers on immunotherapy and radiation necrosis. There's a higher rate of radiation necrosis after immunotherapy, and the curve, the volume curve, has a different slope. So this is predominantly in patients with lesions that are 1.5 centimeters or greater. But in these patients with the larger lesions, the likelihood of immunotherapy-related radiation necrosis is quite higher than if they had not had immunotherapy. Next slide. So this is just a case of, just sort of standard case. Slide on the left is a patient who received gamma knife. We treated him, I think Adrian and I treated him like 10 years ago. He had small cell lung cancer. The lesion responded, but then 6 months later, it came back and it looked worse. And so he got pathology. This is actually before LITT became widely used. But this guy got a biopsy, and next slide, it was progression. Then can you go to the next slide? So another patient, lung cancer. This is with one of our other neurosurgeons. This patient had gamma knife to a lesion, lung cancer in the posterior fossa. 9 months later, the lesion looks worse. This patient went for a craniotomy, and we can, next slide. This one showed necrosis, right? So that's, and you can make the argument, well, this one looks a little bit different than the last one. The last one looked uglier, but the humans are not great at being able to pick out on an image what's going to be radiation necrosis and what's going to be tumor progression. In fact, we've tried to feed these into the artificial intelligence, the AI, and even those are having some difficulty trying to predict, right? So really the gold standard is pathology. And this is just some of the relevant data. As you can see, whether it be standard MRI is just classically poor at being able to distinguish radiation necrosis from tumor progression. They're using more novel and biologic imaging, such as PET and spectroscopy, perfusion. Nothing's perfect, and this gold standard continues to be surgical sampling and biopsy to get path. Next slide. So what do we do here at Wake when we get these imaging changes? So if a patient has a less than 1 centimeter lesion that looks like it's growing, but it's still less than a centimeter, we'll often repeat the imaging in 6 to 8 weeks just to see see what's going to happen, give them the benefit of the doubt. Will it resolve by itself or continue to get worse? Anything, once you get above a centimeter, really want to consider pathologic confirmation. At that point, we have, you can do a stereotactic biopsy, craniotomy, laser. Advantage of lasers that you can do the biopsy and the treatment in the same day, similar to craniotomy, but it's certainly less invasive than the craniotomy. Patients have symptomatic edema, but no mass effect, and they're not on immunotherapy. Sometimes we'll consider short course of steroids or LITT, but LITT does not require us to put them on steroids that might affect the efficacy of their, of immunotherapy. So if they're on immunotherapy, we really are sort of considering more likely that it's some sort of early resection or laser. Next slide. So when tumors do recur, and patients get a surgical resection, they may need adjuvant therapy. Sometimes we'll do SRS to the cavity for a second time. That's been shown to be safe. Sometimes our neurosurgeons will place BCNU wafers, particularly effective against melanoma and lung cancers with particularly good local control of those two histologies. There's now data, Wake was the first institution to publish that you can repeat SRS on the same lesion. So if it's a clear local failure, you can repeat the SRS, but the issue is that is not, there's no pathologic confirmation, so there's for sure a non-zero chance that we're wrong and we're doing radiosurgery on the same lesion a second time, and maybe we're gamma knifing radiation necrosis, which has a reasonable chance of making that worse, right? So that's why it's important for pathologic confirmation. Laser alone can be done for small lesions, and if the neurosurgeon says that they've achieved a complete ablation. Larger lesions greater than 2 cm or ones where the neurosurgeon says that there could not be a complete ablation, those are ones where we'll treat with SRS to the laser cavity, and there's now emerging data for this combination being better than laser alone. And then some patients, systemic therapy is going to be an option, particularly melanoma, mutated lung cancers with targeted agents, and HER2-positive breast cancers. Next slide. And I will pass on to my colleague, Dr. Roy Strowd.
Fantastic. Thanks, Mike. Great introduction. So just to briefly summarize, I mean, a number of important slides. Radiation necrosis is common. It's even more common in the era of immunotherapy and pathophysiologically complex. And so for the next 15 minutes, I want to talk a little bit about just where does this fit in the neuro-oncology space, and for those neuro-oncologists who are on, when should you think about LITT when that patient's referred to you and you're thinking steroids are going to pull the trigger with Bev? When should you pause and really engage the multidisciplinary team to think about laser, or other approaches to radiation necrosis? And so those are the questions we'll address in the next 10 to 15 slides or so. First, just to back up and look at indications for LITT and patients who may benefit from LITT. There are a number of disease processes, brain tumor diseases, where we may consider LITT, and you can see the list here. And I think this really maps the evolution of familiarity with LITT for our multidisciplinary team. A lot of the initial patients were recurrent glioma patients, and then increasingly those with newly diagnosed disease. I think as our surgeons gained familiarity, we tended to bring to tumor board more of those difficult to access tumors, the posterior fossa tumors, as there was additional experience from our team. There's been a ton of use of LITT at our center and many others in brain metastasis, and Dr. Chan really reviewed the value and role there. And increasingly, this area of radiographic progression and radiation necrosis, I think, is an area where we have used and considered and discussed LITT in our multidisciplinary team, and hopefully your teams are as well. Just to briefly summarize patients who may benefit from LITT, these are these kind of buzz bullet points as I'm seeing a patient in clinic. Fragile patients who are poor surgical candidates. Most patients are in the hospital for one night. They're quick in and quick out, and that can be very beneficial for that population. Steroid-dependent patients, we'll see some data from a number of studies showing that we can get patients off of corticosteroids quicker after laser, which can be a real benefit to patients who have myopathy and Cushingoid and just a lot of the complications from corticosteroids. patients with poor KPS who are unable or unwilling to undergo craniotomy and who may not have other options. And so, this is really a tool, a surgical tool available for brain mets, for primary brain tumors, and for radiation necrosis. And we'll talk a little bit about how does LITT fit into that radiation necrosis toolbox from a neuro-oncology perspective. Next slide. So what are the standard treatment options? We'll go through this relatively quickly. This should be review for most on the webinar. Asymptomatic patients with radiographic changes, you heard from Dr. Chan, we tend to watch and wait with serial scans and may consider a biopsy, particularly depending on the timeline of onset of those changes. Earlier changes raising a possibility of brain met failure, and later imaging changes after 9 to 12 months being more likely to be radiation necrosis. And in symptomatic patients, we think of corticosteroids, bevacizumab, surgery or laser, and there's not a whole lot of data, though many of you will know and see in clinical practice things like vitamin E, pentoxifillin, verapamil, and hyperbaric oxygen. I wonder a little bit more about whether we're treating us or the patient, with those agents, but those are considered in some patients. And so I want to focus in the next few slides on just how do we think about steroids, where does Bev fit in, and then how to incorporate laser, at least how I think about laser in patients who are referred for radiation necrosis and in our multidisciplinary discussion. Next slide. So we'll start with steroids. And if you think back to that slide, the sort of pathophysiology slide that Dr. Chan reviewed, there was 8, 9, 10 steps in the pathologic process for the development of radiation necrosis, starting with endothelial injury, and then HIF-1 activation, VEGF expression, and then way downstream is brain edema. And that's really where steroids are acting at the end of this pathologic process. So I think importantly, we think about with patients, this doesn't reverse the underlying pathophysiology. It doesn't stop the progression of radiation necrosis. It is often our first-line treatment for patients, but not without side effects. And you all know well, likely, of the side effects we see: diabetes, weight gain, myopathy, psychosis, insomnia, poor wound healing. And I think immunosuppression is really important to call out here, particularly in the era of immunotherapy, when we are mindful of the negative effects of early corticosteroids in patients who may have good systemic control from immunotherapy. So what's the data? This is a really nice study from a group published in 2018, randomized study of patients with imaging evidence of radiation necrosis randomized to steroids versus Bev. And we often pull the trigger with steroids or think about steroids quickly, but if you look at the imaging, there's really a rather poor imaging response. 20% of patients with reduction in flare, only 5% with improvement in enhancement. And increasingly in my practice and probably in yours, we think early about Bev and bevacizumab in these patients, and there's really promising imaging data. 50% of patients with reduction in flare and a quarter of patients who will have improvement in their enhancement with bevacizumab. And so over the next few slides, we'll talk a little bit about, where does LITT fit in if we're thinking about Bev early, and which patients may be more appropriate for bevacizumab, and which patients may we want to consider a laser approach. So first, a little bit about Bev, and again, I think it's probably review for this group. So bevacizumab is recombinant monoclonal antibody that inhibits vascular endothelial growth factor A, that's circulating VEGF ligand binding to the VEGF receptor. In the brain tumor world, there's no impact on survival, and you all are likely familiar with the common side effects: headache, fatigue, hypertension, proteinuria, and those other more rare but serious side effects: gastrointestinal perforation, venous thromboembolism, wound healing, and hemorrhagic events, which do play into the therapeutic decision-making for these patients. What's the data on Bev? As we talked about, there's not a great prospective study to demonstrate effectiveness of Bev prospectively in patients, but a number of studies, and probably the best meta-analysis is this one here, and I'll show one or two systematic analyses of Bev. This was of 12 studies, about 90 patients, with an improvement in enhancement around in about 50% of patients, and improvement in flare imaging changes in 60% of patients, an overall response rate of 93%. So you look at this and you say, wow, Bev just works and it must work well. It should really be a first-line agent. In the one study that looked at recurrence, 77% of patients will recur, after discontinuation of Bev. And I see this time and time again in my practice. Patients go on low-dose Bev, we treat them for 4 cycles, 2 months or so of treatment. The imaging looks a lot better, patients feel better, and then 3 or 6 months down the road, we're back in the same situation, having to rediscuss imaging changes. Is this now disease? Is this radiation necrosis? And reinitiating bevacizumab at that time. And so I think these data are very attractive for considering and discussing this with patients, but there may be a group of patients that could benefit from perhaps a more durable or definitive therapy early in the setting of radiation necrosis before that initiation of Bev. Next slide. So this is just a summary and a review of the data on Bev. There's no level 1 evidence, no FDA indication, and as Dr. Chen likes to say, the best study was not actually the best study. So the Alliance phase 2 study to look at really demonstrate the efficacy of bevacizumab for SRS in patients with brain metastasis was closed due to slow accrual. This was steroids plus Bev versus steroids with placebo in patients with confirmed radiation necrosis. And I think this is likely because of the more widespread use of bevacizumab in this patient population, and is encouraging that bevacizumab is out there and in use, and also a caution of considering in patients as we're seeing them in clinic, and certainly in my practice, of bringing these patients to Tumor Board, having that multidisciplinary discussion to determine what the best therapeutic option may be. Surgery is the gold standard, as Dr. Chan said, and really can be helpful for patients with those large, singular lesions with increased intracranial pressure, with survival benefits, and as one option. Next slide. But then really, where does laser fit in, and where should we consider LITT in these patients? As this group, as you likely well know, this is a minimally invasive surgical alternative to surgery, provides an opportunity for pathologic confirmation. We see consistently in studies decrease in steroid dependence and achieving steroid independence, which is really important in the patients that I see. And rather importantly, this is in the NCCN guidelines as a treatment for primary brain tumors, brain metastasis, and radiation necrosis. And I think this is helpful as we're looking to get approval and authorization for the treatments for our patients to point to this. So here that is as a review for many, or an important observation for some. LITT is in the NCCN guidelines, and as you can see here, clear a guideline to support its consideration for patients who are poor surgical candidates, that group that I mentioned at the very beginning, for recurrent brain metastasis, radiation necrosis, and recurrent glioblastoma, allowing both that diagnostic confirmation and an early treatment option. So at the very end, just want to point out some studies of for the neuro-oncologist, when you're seeing these patients, how do I consider, how does our team consider Bev versus LITT? What are those discussions and data that we're using to inform those decisions in our tumor board? And there's not prospective data comparing Bev with LITT, but 2 studies that I think really inform practice and that I use as a guide in thinking about these patients and do come up in our tumor board. So this is a literature review of 18 studies. There is a potential for selection bias here. These were retrospectively evaluated patients, 143 with radiation necrosis that received Bev and 148 that underwent LITT. In this review of patients, both were equally effective in treatment of symptomatic disease, symptomatic improvement, steroid cessation, and immediate lesional control. The Bev group had higher imaging response rates, and we'll show that in the next table. Not surprisingly, given what Bev does to scans, makes the scans look better and improves symptoms and helps patients to wean off of steroids. We see more stable disease, but more likely to stable disease in the LITT patient. I think importantly and interestingly, survival rates were superior in the LITT group at 18 months. We can go to the next slide to see the actual data from this study. So in the middle of this table, we see that imaging changes. So higher partial responses in patients receiving BEV compared to stable disease. The next line down in those receiving LITT, not surprisingly, just based on how those two things work. If you look down at the bottom in terms of overall survival consistently higher in the LITT group. We see 94 to 90, 92 to 80, and this sort of growing trend as patients are followed longer to improve survival in patients receiving LITT. So I think provocative data, interesting, prompts a lot of discussion for our group in terms of what may be going on, and takes me back to that pathophysiology slide of perhaps LITT really acting more proximal in that initial endothelial injury process that we may not see with BEV, and the kind of higher recurrence rates may be playing a role in some of these data. Next slide. And then to end, there's one additional single institution study supporting the same phenomenon, again with longer overall survival in patients receiving LITT compared to BEV, 25 months versus 15, again limited by the retrospective design, but kind of provocative data to consider. So in conclusion, biopsy is important in these patients. Craniotomy plays a role, but LITT really is an optimal tool in the toolbox for patients with radiation necrosis. And to guide us through some cases and additional consideration of how to put this all together, we'll go to the next slide, and I'll turn it over back to Dr. Chan.
Thanks, Rory. So I'm going to go over a little bit about the Lantern Registry. This is the prospective multi-center registry of real-world outcomes for patients who have had laser LITT. This is, really applause to the company Monteris for really helping to keep this data and prospectively collected to actually be able to demonstrate for the community, for the insurance payers, and for patients and their families, the safety and efficacy of laser in real world practice. So several Lantern publications have now been published, including the one that our group actually helped spearhead in neuro-oncology advances earlier this year. Next slide. And so in our study, it is the largest study so far to date for patients who were treated with laser for radiation necrosis. So we look particularly at what was the efficacy of these laser in this particular population. So these 90 patients over 14 US centers, and they must have had biopsy proven radiation necrosis, so not tumor progression, not a mixed picture, looking at outcomes such as time to steroid cessation, continuation of systemic therapy, local control, and continuation of their performance status. Next slide. So basically the median time for discontinuing the steroids was 13 days. If you actually look at the table or the graph on the right, the vast majority of the patients actually had were able to discontinue steroids within those first 2 weeks. There are a few outliers that really increased the mean, but ultimately the vast majority of patients were able to discontinue steroids quite quickly within the first couple of weeks. Performance status remained stable over this 2-year follow-up. And then, as you can see, a proportion of patients, 40% of patients never stopped their chemo, nearly 20% of patients never stopped their immunotherapy. And these are sort of artificially depressed numbers because it is often, because immunotherapies are new, lasers a little bit of a newer technology, oftentimes the patients have, or the practitioners have tried to err on the side of safety and not continue systemic therapies due to fear of increased wound healing issues. But as you can see, a significant proportion of the patients, in spite of this bias, were still able to continue on with systemic therapy, which can be a very useful thing to know, particularly in patients where they may have rapid progression of systemic disease if they take a chemo holiday. Some diseases such as HER2-positive breast cancer, as well as some types of renal cell cancer can have really rapidly progressive disease if the systemic therapy is halted. Next slide. And so in our study, we found that laser for radiation necrosis was a durable, safe procedure, low patient morbidity. The local control was 90%, regardless of whether they had a complete ablation or subtotal ablation. So unlike with recurrent tumor, you don't absolutely need 100% ablation to halt the progression of the radiation necrosis cascade. If you ablate a good majority of the lesion, that's likely enough to stop this progression of that cascade that leads to the significant inflammation and edema. And so 75% of patients did not require any further treatment for that lesion for the duration of the follow-up of the study. And LITT-related severe adverse events were very rare at 2%. Next slide. So laser represents a very helpful option for patients who have radiation necrosis. It may allow us to use more aggressive radiotherapy. So patients who may not be candidates for upfront surgery, if we can be more aggressive with the upfront radiosurgery, knowing that we have laser in our back pocket if the patient does get radiation necrosis, it allows us to shoot for the local control instead of skimp away on the dose. It's been shown in several series at least, that if patients have tumor progression as opposed to radiation necrosis, the patients with tumor progression tend to do worse. They have worse local control, they have worse survival. But having laser as a minimally invasive option, an effective option for patients with radiation necrosis, it's a good thing to have in our armamentarium. And so next slide. And so basically, advantages of laser is that when a stereotactic biopsy is done on the same day, we have diagnostic confirmation, we can do the treatment all in one procedure. It allows for prompt cessation of the steroids with symptom control, particularly helpful in cases where patients are on immunotherapy. May allow for continuation of chemo or immunotherapy in patients where their disease is really dependent upon the systemic therapy, and some of the patients can have rapid progression of disease if the systemic therapy is halted. And then having laser as a salvage option may support more aggressive use of radiation or radiosurgery. At times of tumor recurrence, being able to do SRS on the same lesion a second time, or being more aggressive for larger lesions up front. Next slide. And I'll pass on to Dr. Laxton.
Great, thanks, Mike. So I'm going to touch on, sort of reiterate some of the discussion we've had on the importance of biopsy. So the symptoms of radiation necrosis and progressive tumor can overlap. And so just as the MRI findings, the imaging findings overlap, so can the symptoms. And there are potentially clinically significant implications of that inability to differentiate them. So believing or thinking that radiation necrosis is tumor could possibly lead to further radiation, which is exactly what those patients likely don't need. Similarly, assuming that it's just radiation necrosis and thereby delaying further cancer treatment could be a bad thing for that patient. So the biopsy is important. Next slide. And so one of the nice features about LITT is that we can combine tissue diagnosis with potential therapy. And so that may, by allowing that early tissue diagnosis, that may then enable the oncology team to initiate other therapies that they think may be relevant for that patient. And similarly, the ability to provide that actual treatment as well in one sitting, not just providing the diagnosis, which is a treatment, as we've been discussing, that can be very effective, whether or not we're dealing with progressive disease, recurrent tumor, radiation necrosis, or mixed pathology. So a combination of both radiation necrosis and tumor. And so by providing that therapy, we may again be able to avoid long-term steroids and manage seizures and maintain quality of life and KPS. So next slide. And so we'll move on here. So studies that have looked at this, a recent one from 2022, last year, looking at combining LITT and radiotherapy for patients with proven recurrent metastases is perhaps the best approach of all. So in this study, they looked at patients who'd undergone LITT plus SRS, LITT alone, or just SRS. And so the patients who underwent LITT and SRS had a median freedom from local progression of around 30 months and a median overall survival of about 12 months. That was significantly less in terms of local freedom from progression with LITT alone, and even less progression-free survival with SRS alone. So again, in this sort of retrospective series, suggesting that the combination of LITT plus SRS may be particularly relevant in those patients with recurrent tumor. Next slide. Looking at the issue again in radiation necrosis, one of the important issues is how long is this patient going to need to be on steroids? And so this was a multi-center retrospective case series that looked at 81 patients, 57 of whom were treated with LITT and 15 who were treated just with medical management steroids alone, generally dexamethasone. And so looking at this, the 84% of patients who had LITT were able to wean off steroids, whereas only 50% of those who had steroids alone were able to wean off those steroids. And so radiographic progression of these lesions was very rare at only about 5% of patients who underwent LITT and closer to 30% in patients who had steroids alone. So again, suggestive evidence that when the setting is radiographic progression due to radiation necrosis, LITT may have an additive benefit as compared to steroids alone for these patients. Next slide. And so to look at this question in more detail, we've embarked on the remaster trial. Dr. Fetchy from Duke is the overall PI on this, and I'm the PI at Wake. And this is a study that we've begun at our two institutions to get a better understanding of this issue that has been suggested in retrospective series. Next slide. So in this study, what we're trying to establish is LITT plus biopsy is a first-line therapy in instances of radiographic progressive brain metastases. And so whether that's progressive disease or radiation necrosis, and provide evidence to guide this adjuvant therapy use. So we're comparing the efficacy of two sets of treatment algorithms and what the potential role for LITT and other therapies is in these two groups. So these two groups are patients who, so they've all previously undergone radiosurgery or radiation. And so subsequent serial imaging has revealed radiographic progression. And so in those patients, they can then be entered into the trial and entered in for surgery. And so in surgery, they'll undergo a biopsy, which will determine whether or not they are in fact progressive disease or radiation necrosis. For patients who have progressive disease found on biopsy, all of those patients will then go on to get LITT. What they're randomized intraoperatively to, though, is whether they will, following LITT, get early radiosurgery. And those patients who are found on biopsy to have radiation necrosis, their intraoperative randomization determines whether they will then go on to just further steroid management or whether they will get LITT at that sitting. And we again have started this at Wake and at Duke, but we are very interested in expanding recruitment as well. So next slide. And so in terms of the objectives of the study, in the recurrent tumor or progressive disease cohort, we're looking, and so these are the patients who got LITT and plus minus based on randomization, additional stereotactic radiosurgery. We're looking at their time to local intracranial progression or neurological death. For those patients who are in the radiation necrosis group, so those are the ones who've been randomized to either get LITT at that OR sitting, or to subsequently go on to just stay on steroids without LITT at that time. And what we're looking for there is their time to steroid independence or steroid cessation. And so the secondary objective for all groups is overall survival. Next slide. And further sort of exploratory objectives, we're going to be, and we have been looking at patients' quality of life and cognition over time, explore the relationship between radiographic features and biopsy results, and analyze radiographic changes over time. So both try to get a better understanding, can we differentiate the radiographic features of these two clinical entities and how they may change over time with and without LITT, and explore outcomes of salvage therapy. Important to understand in this study that it's very clinician driven, and if at any time, whatever group the patient is, the clinician feels they may need further surgery, further radiation, further steroids, or Avastin, or whatever additional therapies that may be required, that will still be integrated into our analysis of these outcomes. Next slide. So the next is just a series of some cases, and it's just to give it's not meant to suggest that these are the correct answers to these clinical problems. These patients are complex, and really what we're highlighting again is this notion that there is a expanded and expanding armamentarium of options for patients in these situations. And that's really what I want to highlight with showing some of these slides. So this is a lung cancer patient with brain mets who's demonstrating local failure 2 years after SRS. And we can see that this lesion against the right lateral ventricle is expanded. Next slide. And so options for something like this, we can see significant expansion and a challenging area potentially to access with open surgery. We can use a combined approach of LITT, which entails biopsy confirmation of what we're dealing with, and then having found that it is local failure and progressive disease, can then go on to apply more radiosurgery in that situation. Next slide. In this situation of a patient with melanoma with local failure at 1 year after SRS, and we're seeing increased edema and enhancement extending beyond the previously treated SRS volume. Next slide. So again, confirming what we're dealing with a biopsy and LITT. And again, this was quite an aggressive process. So finding that the tumor had expanded quite significantly, applying a hypofractionated radiosurgical approach to the LITT cavity. So again, combining radiosurgery and LITT, but in this case, because of the tumor volume that we're trying to treat, using a hypofractionated approach for the subsequent radiosurgery. Next slide. Here's a situation where on first glance, we think we're just looking at the previously treated tumor, but in fact, what we're seeing on subsequent imaging on this lung cancer patient 9 months after SS is marginal failure. So the area that appears to be increasing is actually not undergone radiosurgery, and so in this instance, repeating SRS is a viable option. In a sense, we're treating a new area. And so we can avoid potentially early surgery in this situation, obviously following it up with serial imaging and responding as needed, but a nice sort of nuance of when we might be able to offer upfront sort of repeat SRS. Next slide. Here's a situation with a metastasis in the midbrain, which again is a challenging area to access surgically. And so LITT, again, confirming diagnosis, but also providing a treatment in a safe way in this situation where, again, even repeat SRS may be inadvisable in a location such as this. Next slide. Now a nuance on that, we're seeing sort of progression along the CSF surface in the brainstem, and so we may want to apply, and it's a small volume, we may want to apply a repeat SRS in this situation as opposed to certainly open surgical treatment, and even in this location with a small volume, although we may want to treat it, even LITT may not be preferable at that particular moment, but obviously it will be reviewed on an ongoing basis. Next slide. And back to Dr. Chan.
Great, thanks, Adrian. So, so where are we heading? So I think that it will be quite interesting to see the ultimate results of the remaster study, because early efficacy data seems to suggest that there's a combination between laser and SRS for progressive tumor is effective, and in fact, laser may actually even act as a radiosensitizer, and that's a hypothesis that's being studied right now. And then again, having LITT in our back pocket as a known effective salvage option may allow us to be more aggressive up front with the SRS, whether it be with hypofractionated for larger lesions, a two-stage treatment for larger lesions, repeat SRS in lesions that have previously been treated, or for marginal failures. It allows us to know that we at least have a safe salvage option. And I think that what that does is it highlights the dependence and interdependence of these multiple disciplines, right? In order to come up with the right answer, it is helpful to be able for me to talk to Dr. Laxton, talk to Dr. Strowd, right? If a patient has hemorrhagic melanoma, and then what may be radiation necrosis, Dr. Strowd may tell me, hey, I'm concerned about the hemorrhage, for Avastin. Maybe you want that might not be the best option, right? And then other times, Dr. Laxton may say, hey, what do you think about possibly doing a repeat SRS because I'm concerned about, I'm concerned about how eloquent that area is, right? And there may be other times where, where something, the cumulative radiation's volume is high, and I'm, because multiple SRS treatments have been done around the same area, where I have to tell Dr. Laxton, hey, laser is going to be the best option here, because if I do more radiosurgery in this area, it's just going to cause necrosis, right? And these are just a few different situations or nuances of management, how the multidisciplinary discussion can be really vital and can help the patient end up with a better outcome. Next slide. So in summary, again, that's a major point. Multidisciplinary discussion and management leads to best outcomes. Laser represents a really effective and also, minimally invasive option for these less than 3 cm lesions. After SRS, they show progressive imaging changes. Radiation necrosis events are expected to continue to increase based on more aggressive radiosurgery practitioners and more aggressive use of immune checkpoint inhibitors. Radiosurgical laser cavity, it may improve local control, and that may be ultimately where our field goes in terms of adjuvant treatment after laser for pathologically proven progression. And then, laser allows us to have pathologic confirmation treatment on the same day. It decreases time to steroid independence and less burdensome than craniotomies for both patients and then just the hospital system in general. So, it is something where we at Wake Forest, the team at Wake Forest, is grateful that the Monteris team has allowed us to come on and give this talk to you guys today. I think that we have a very high volume practice and have really managed to integrate laser as a really critical tool that we as a team use in the management for the benefit of our patients. So with that, I think we are happy to take any questions.
So something that frequently comes up when we talk to various institutions are for those patients who maybe present with symptomatic radiation necrosis and they are treated with bevacizumab and then additional intervention is needed. If laser ablation is selected, what type of washout period would you recommend before laser ablation can actually occur after the BEV?
I would say Roy and Adrian may be sort of, their expertise may be better than mine for this one. I know that for the patients that I've treated with them in the past, something like a month is what I have seen, but I don't want to put words in either Adrian's or Roy's mouth.
It certainly is a challenge, and so one way to look at your question, Krista, is you may have wanted to decide on surgery before you went down the road to Avastin. And I think generally, we meet every week as a tumor board, and that's going to be one of the discussions. So when we get to the point where we're thinking the patient would be best served with Avastin, we may have gotten to the point where we're thinking surgery may not be optimal for that patient. I
couldn't agree more. I mean, I think the standard answer would be 6 weeks, and certainly no less than 4, and in an emergency, no less than 2. But I agree with Dr. Laxton. I mean, that is the point of these conversations, is to really be thinking about that beforehand. I'm often not in the situation where a patient is having, if it truly is radiation necrosis, progressive changes on Avastin. More frequently, it's where Avastin, bevacizumab worked, the imaging got better, and then we're back in that same scenario, a month or 2 down the road. And I do think that is a time to pause and think about, do we just restart the bevacizumab, or is there a better approach to this patient's radiation necrosis? Are we going to achieve a durable response? There's at least one patient on my mind that went to laser and then it was sort of done, didn't need to treat that anymore. So I think it's a great question, and it's a really important patient safety question. But I like the response of sort of bringing that thought process early in the treatment decision.
And then one final question, just to be respectful of everyone's time. Can you comment on some of the radiographic and maybe clinically meaningful changes that occur after a patient receives laser ablation?
So typically we talk about an early sort of rim enhancement that actually tends to persist. So 3-6 months down the road, that can even be what we call an eggshell, quite a thin rim of enhancement, and that sometimes we see that getting smaller, and that certainly is the case, and particularly in the setting of a patient with metastases, and these are often patients who also get stereotactic radiosurgery, where we ultimately may see complete elimination of the lesion. But it really sort of depends on the clinical entity. When I think of sort of glioma patients, that's kind of a middle ground where we may see evidence of the area of ablation, but an increasingly benign appearance with much less perilesional edema over time. That can be sort of what we see over time. And if I think of our patients with epilepsy and say getting mesial temporal lobe LITT procedures, then what you ultimately might see is sort of a coagulative necrosis. You'll still maintain that rim of enhancement typically, but essentially T2 hyperintensity and a complete elimination of ablated structures. So
I had a quick question. So for patients with brain metastases who have seen SRS and LITT sequentially, either one after the other, and if the lesion is yet progressively getting worse on the MRI, what would you recommend for those patients outside of aspirin and bevacizumab? Are those lesions candidates for getting combined LITT and SRS that have seen SRS and LITT before, but not in combination?
potentially, yeah. The details, of course, would matter, and I'll let Dr. Chan speak about the subsequent radiation options. Certainly, LITT is not. I wouldn't equate the two in terms of considerations for repeating. In and of itself, a LITT procedure can be repeated in an area or adjacent to an area or in a similar region, and so in and of itself, that definitely could be repeated. Depending on the location in that situation, though, as you're alluding to, you may want to consider other things. And certainly, if it was safely amenable to resection, that might be the next move. This is becoming a larger lesion. Presumably, it may be pushing volume limits on both LITT and/or radiosurgery. And so, you might want to very strongly consider resection.
Yeah, I think that that's a great answer, Adrian. And my sense is that when it comes to radiation and radiosurgery, there are lifetime tolerances, right? And so we have a much better idea now what these lifetime tolerances are. Patients can receive radiosurgery on top of a prior radiosurgery, right? So if they get laser followed by another radiosurgery, that is reasonable, so long as you respect the volume tolerances. Now, if the original laser and SRS to the laser cavity was larger, like pushing 3 centimeters, and then now you're going back and you're treating another 3 centimeters. Second time around, we would certainly hypofractionate as a way to sort of be more gentle to the normal tissues, right? Hypofractionation is certainly better tolerated than a single fraction for large volumes, right? So we would certainly consider that when we gave the second round of SRS to the same volume, if it's larger, if it both times were, close to 3 centimeters or both times are greater than 2 centimeters, we would, the second time around, we would hypofractionate it.
I forgot to mention in my question if the patients are not a candidate for surgical resection, because I vividly remember a patient that I had of, I think, lung or breast cancer brain metastases, and she saw SRS followed by, I think 2 years down the line, got LITT, and only was getting worse both radiographically. Well, she did have some response to LITT for the first 2 scans, but then radiographically and clinically was worse. So I wonder, is there a trend that brain metastases patients follow after LITT that, they can get worse initially radiographically before it gets better?
So I think that it very well may be what occurred in your case. Do you remember with the LITT, was it radiation necrosis or was it tumor progression, the first LITT?
Yeah, good question. So she, her LITT procedure, it was not documented as tumor progression.
Meaning it was documented as laser or was unclear?
They didn't mention it as tumor progression. It just mentioned inflammatory cells and glial.
Okay. Sure,
Yeah.
sure. Yeah, I mean, in general, laser is very effective for radiation necrosis. Now, it's certainly not 100%, but 90% is quite good. There will be some lesions where the patient will have sort of a persistent necrosis type of picture. And a common scenario for that is if you're pushing the volume limit. So if it's large to begin with and there's a lot of edema, those patients may be ones that are more difficult to get off of steroids and may sort of have a bit higher likelihood of progression. In this kind of case, if you don't have documented tumor progression, you don't want to do SRS to that same volume again, because if it is tumor, if it's necrosis both times, right, then giving more SRS to an area of necrosis is going to make it worse, right? Now, having said that, there are some scenarios where a patient has radiation necrosis is treated with laser, and then ultimately they may develop a tumor progression in that area, right? If you wait long enough, that can happen, right? So the second pathology is quite important to know what to do. If the second pathology is tumor progression, then yes, we would offer SRS, to the laser cavity after the second LITT. And in fact, this is one of the major advantages of LITT, is that it allows you to get the pathology on the same day in the same procedure.
Is there an optimal radiation dosing strategy after treatment with LITT?
So I guess I'll take that one as the radiation oncologist. But so we tend to use a very similar strategy as what is used for treatment of a resection cavity, right? So if you're treating up front for a resection cavity, we tend to, try to achieve doses of 15 to 18 gray, right? Now, if they've had SRS to that cavity before, what I tend to do is I will hypofractionate if both volumes were large. If the original volume was a really like a less than 1 centimeter thing and ultimately progressed slowly over time, you had to laser a lesion that was almost 3 centimeters, that progressive cancer is kind of eaten away most of what had previously been treated with SRS, right? And so in that kind of scenario, I essentially will treat it as if it has not really seen SRS before, right? And just because the SRS volume or the second volume is much bigger than what the original tumor is. But again, we would use similar fractionation schemes as to what is done with surgery to the resection cavity.
Okay, well, I would like to thank everyone for attending, and I hope this discussion was beneficial in helping to dissect how LITT might benefit patients with recurrent metastatic disease, whether it's thought to be tumor or radiation necrosis. A huge thank you to Drs. Chan, Strowd, and Laxton for taking the time to do this webinar and to share their own experiences. So thank you very much, everybody.